get you to stand there in a minute. I'll do it for you. Perfect. And if you speak, then I've got a handheld mic to questions. Okay. And I'll do a quick trick
That's fine. And presumably the acoustics.
Yeah, I think some people will be using the loops and so on, which is fine for me. And also that takes the feed to the live stream.
Sounds good.
Start. That's connect. Hello and welcome to Leicester Cathedral this evening for this Far and Near lecture. I'm David Monteith, the Dean of Leicester, and it's very good to welcome those of you who are here in the Cathedral, but also good to welcome those of you who are joining us online. Last year when we did the Far and Near lecture, everybody was online, and I can remember it was Lady Hale who was talking with us, and I was trying to juggle all of your questions and try to make them into something intelligent to keep the dialogue going. And I remember switching the computer off at the end of it and lying down in a wreck. So it's much easier to deal with people in the room than it is to deal with screens all the time. Welcome to those of you online, including, I know this evening, Dr. Ivan Brown is joining us online. Ivan is the Director of Public Health for the city here and a good friend of the Cathedral, and he wanted to be here, but he's with us online since one or two things that are going to be discussed had a little to do with his work as well during this last time. In lockdown, I found myself digging deep into my own history, and in particular into my life as a zoology undergraduate, as I found myself having to regularly write thought pieces on things like antigens, antibodies, immunology, and indeed discussion of this wonderful number R, which I last wrote about in a finals paper at Durham University in 1988. So it really was digging quite deep, but I found myself writing about those things in relation then relating those to community, to health, to neighbourliness, to the world, to faith. And I'm sure little did those who work as researchers in this field necessarily expect to find themselves becoming household names. But that has happened. And suddenly the connections between research, politics, health, inequity, poverty, diplomacy, and us, the community, are revealed. And so Andrew Pollard's name has become the subject of breakfast table discussions and car journeys as he and his many colleagues, not only from the Oxford Research Group, but the wider community working on this vaccine, suddenly that whole community has become part of our ordinary lives. And indeed, many of us, and no doubt including in this room this evening, now carry bits in our bodies that have been reshaped by an AstraZeneca intervention. But additionally for us, our speaker has distant family links with this place through the Shaw family. Dr. George Shaw and his wife Julia are buried in the east end of this cathedral building. George was an eminent doctor at the Leicester Royal Infirmary from 1840 to 1870, living literally just across the way in New Street and being the church warden here at St Martin's, Leicester. George also worked in epidemics. He worked and helped resolve the cholera epidemic in Manchester in 1832. His official obituary says this: he distinguished himself by his ability and devotion to the severe duties devolved upon him during the terrible prevalence of the epidemic. Words that struck me that probably just as easily could be used of Andrew Pollard today. And the commemoration windows in the Great South Aisle which recall the Shaw family are depictions of stories of the resurrection, stories of new life coming out of terrifying darkness. Equally, perhaps, appropriate for the theme of tonight's lecture, Hope Through Dark Times, a Vaccine Story. Would you please now welcome our guest speaker from the University of Oxford and the director of the Oxford Vaccine Group, Professor Sir Andrew Pollard.
Thank you very much, and thank you so much for inviting me to come and speak here today. What I'd like to do to start off is just perhaps ask you to think about a situation, maybe it's not so difficult to do so, where you're frightened to go out, where you're staying at home, and members of your family, people you know and love, have died as a result of a disease that is spreading around the community here in Leicester. Just also imagine a situation where we have no idea what this disease is. We don't know what causes it. And we now are able to recognize it because it has effects on people that are visible. And that scenario, I mean, it might seem quite familiar to us, was actually a scenario that happened here across the whole of England, but here in Leicester, in the 1300s. And that disease was the Black Death. The Black Death arrived here in England around about 1346. It actually swept across the whole of Europe. It came into cities probably originally spread by rodents, but most likely because of the very rapid spread in the 1340s. It was fleas on humans because of the terrible conditions that we were all living in. Well, some of us weren't around then, but the older members of the audience might have been living then. So spread between people and spread very rapidly through communities. About half of the people infected died. So across Europe, half the population of Europe was wiped out. It then took another 100 years for the population of Europe to return to the size that it had been before. And I start off by mentioning that to sort of frame what pandemics can do. Just imagine half the people in this city dead. And in many ways, what we're facing here, although it's been that first bit of my introduction about staying at home and scared and people dying, we are actually incredibly fortunate that we've been dealing with a virus that has less than 1% mortality. We know that it's a virus. We know a lot about it, which I'll come on to. And although there's been huge fear, it is completely different from a situation that people would have been in here in previous pandemics, not knowing what was causing it, not really understanding, but seeing people dropping dead all around them. And with this particular disease, Black Death, with horrible buboes, which are dying glands, so lymph glands in the neck and under the arms and so on, that have become blackened and swollen. And as you mentioned, George Shaw arrived here in Leicester, not initially at New Street, but eventually there a few years later, in 1834. And he was facing then a cholera epidemic. He dealt with one in Manchester, and maybe he came here to escape from the unpleasantness of that. But cholera arrived here in Leicester in 1849. And so just a few years after Dr. Shaw arrived here, he was faced with another epidemic, the epidemic of cholera. Now, sadly, cholera, unlike plague, which is now very rare, cholera is still quite common in the world. And I've been to areas in South Asia where cholera epidemics are occurring. And unless you can treat the individuals, mostly children, very rapidly, they will die just because they have such severe diarrhea that within a day they've lost so much fluid from their bodies that they die. So that, I can just imagine myself what it must have been like to being a doctor in the face of a cholera epidemic with no possibility of rehydrating those individuals affected by it. I'm here again in the city of Leicester. Today, with modern treatment and indeed with vaccines, we can both prevent cholera but also successfully treat it if we get patients early enough. So it really reminds us just what an enormous change there is in our ability to understand the diseases, but also to prevent and treat them. So perhaps to come on to the last 2 years, I don't know whether you remember in January last year, I think the main thing that was concerning us was the Australian bushfires, which there was so much smoke from them that you could see the bushfires in Brazil. You see the smoke in Brazil blowing across. And of course that, with COP26 just having happened, it's sort of a throwback to 2 years ago with the effects of climate change on our societies. But at that time, even though none of us here were even thinking about coronavirus and whether there might be a pandemic, the genetic code of the virus had already been sent to the lab in Oxford, the 11th of January. And it was sent because it was another new coronavirus that people hadn't seen before. And it was sent because it was interesting to see whether we could make vaccines from it, just in case it turned into something which might cause a small outbreak in China. And maybe we could be helpful. And so there was a project that started long before we saw any cases here. In fact, the first case outside of China was 3 days after the genetic code of the virus had already been sent all over the world so that people could think about making vaccines. So we really didn't know at that time that there was going to be a pandemic. We were very unaware of what was about to come. It was last year, I think, an incredibly dark time as we saw people being affected, first of all in Europe with the horror of what happened in the northern part of Italy, and then eventually by the end of January, early February, the first cases here. And I don't know whether you remember the media reporting, but still people were saying, we've got a better health system, it'll be fine. But as February continued last year, things got worse, and it became clear that this was going to change our lives forever. The predictions from the mathematical modelers in February last year, and you may remember this, suggested that between 300 and 500,000 people would die in this country. And the modelers have been very criticised for those scary numbers, but actually they're right. If you look at where we're up to now, 140,000 people have died from the virus, and we know from the analysis done this year, the vaccines have prevented about another 120,000, maybe even more than that. So we're already at a point where without vaccination, we would have been at somewhere approaching 300,000 people dead. So the modelers were right. We really were facing one of the darkest moments in our lives, certainly since the Second World War. But it really isn't like the situation back in the times of the Black Death, because we knew the biology of this virus. In fact, there have been 2 previous outbreaks of coronaviruses, one 20 years ago and one about 10 years ago. And those coronaviruses were viruses which didn't spread very well between people, fortunately. One of them, called SARS, killed 11% of the people it infected. And the more recent one, which came from camels originally in the Middle East, killed 1/3 of those who were infected. But fortunately, it didn't spread very well between people, and so you could recognise the cases, isolate them, and stop anyone else getting ill. But the reason why we knew a lot about the biology of coronaviruses and how to make vaccines was those events made us in the scientific community very worried that coronaviruses would cause a pandemic. And in 2015, as a result of the outbreak of Ebola in West Africa, the government put money into developing vaccines for possible outbreaks, possible pandemic threats. And some of that money went into making a vaccine for the MERS coronavirus, the one that came from camels in 2012. And so we'd already done the research, how to make the vaccine. We knew that spike protein, which we're now all experts in, was the critical bit of the virus to put into a vaccine. And we'd even done trials, phase 1 trials, in healthy individuals, both here and in Saudi Arabia, with a coronavirus vaccine for MERS. And so actually, when we had the genetic code of the virus in January, it was relatively straightforward to say, well, let's just switch out the MERS genetic code for spike protein and put in the genetic code for this new virus, SARS-CoV-2. But it is important at this moment to say that we're lucky with coronavirus because we do know about it. But there are a lot of other diseases which today we're still blind about. Now, although we would understand a lot more with the science that's around how we might approach it, we would still potentially have years of work to do, even to get to that first moment that we had this year when we could switch out and actually start making the coronavirus vaccine. We have today, fortunately, a whole range of different vaccines that are available, and we're all now experts in types of vaccines. There's the RNA vaccines from Moderna and Pfizer, the viral vector vaccines from Oxford and from Johnson & Johnson, and in fact a Chinese company, CanSino. Much of the world has actually been vaccinated with what are called inactivated vaccines, and these are where you grow the wild virus and then kill it with chemicals. And that is the same as the polio vaccine that many people, at least your children, will have had. In fact, many of you will have had the live polio virus vaccine rather than an inactivated one. And the inactivated vaccines have been widely used in Latin America and Africa and in China and other parts of Asia. But the Oxford vaccine is one that is based on a different type of platform technology, the viral vector. And it's made from a chimpanzee adenovirus. And these are common cold viruses that affect chimpanzees. And the virus has been grown in the laboratory and it's been altered so it can't cause infection in humans. And so it's safe for us, it's safe for anyone, even if they're immunocompromised, if they've got cancer, anything. It's a safe vaccine. And we've just put the genetic code for the spike protein into it so that when we give the vaccine to people, our immune system sees the spike protein and we make an immune response against it to protect us. And I think one of the other things that's, for me, is a really important memory of last year was the amazing sharing and collaboration between vaccine developers. That's not something we normally see on the scale that we had. I was about to start clinical trials of our vaccine to see whether it was safe and made good immune responses in phase 1 in humans in Oxford, and I contacted a Chinese developer to talk to them about their product, which was very similar, and their experience, and they shared all of their data with us that helped inform regulators here in the UK about what we might expect and to give us confidence in giving that first dose. Normally, when you develop a vaccine, you start off with that research bit, do some animal studies, and then you've got some initial data, and so you then try and find someone to fund the next stage and to do phase 1. That's usually about another year's wait just to get the money to start making the vaccine. Then to make the vaccine, you have to find space in a manufacturing facility. And the last trial I did, it took 18 months to find the space in a manufacturing facility to start making it. So that's still, we're already about 3 or 4 years on into development normally, and by the time you've even started giving the first dose to humans. And then, of course, with the results of that initial study, you can show it's safe and it makes an immune response in maybe 50 or 100 people. You then have to go back to funders and ask them to fund the next stage, which may then take another year just to get the money. So it's not surprising that for most vaccines that have ever been developed, it's somewhere between 5 and 15 years before you actually have a product that's available. And so what we had to do in the pandemic, and of course many of us recognized last year that there was no way out of this without a vaccine. We would not be able to develop treatments which could save lives and get societies back to normal. We had to have a vaccine. And so we put all of our efforts into thinking what was needed to move quickly. And there's 2 key things that are needed to move quickly. One is guaranteed funding, so that you don't have to have these long delays for funding. And the other is manufacturing capacity. funding was still, surprisingly, was a problem in the pandemic. The government funded trials here in the UK, but that's not enough to get an answer quickly. And so we had in Brazil to work with a foundation called the Lemon Foundation, which is a foundation belonging to a wealthy family who have a drinks franchise in Brazil. And in South Africa, the Bill and Melinda Gates Foundation funded the trials. So finding funding required huge efforts to go around and find people just to pay for that initial work to get started. And then the next really important step is being able to make enough doses. And that was a huge problem here in the UK in February 2020. We could make about 1,000 doses in our manufacturing facility in Oxford, but that is not nearly enough. And so we had to work with a company in Italy who were able to make larger numbers of doses before eventually we were able to get AstraZeneca on board to make the very large numbers needed for the phase 3 trials. So just getting manufacturing on the scale needed is a real hold-up. And a lot of the progress that has been made in the last 2 years has been made because so much has been done at huge financial risk. So the upscaling of manufacturing of millions and now billions of doses of vaccines was done by all of the developers before they even knew that the vaccines were going to work. It's a huge financial risk to take on, to build up capacity to be able to do that. So no corners were cut. Right? And the regulators are very tough with us about that. The shortening of timescales is all to do with having these processes overlapping and being able to look at the data in real time as we move along. And I have to say, for me, that what I've just described to you reflects the most enormous amount of pressure to move swiftly, because every day, when you looked at the global figures, 10,000 people were dying. And so even a few days' delay has this enormous impact on the world's population if you don't have a vaccine for them. So the phase 1 trials are directed at individuals who are healthy. So it tends to be younger adults, and lots of people get excluded because they've got minor illnesses. And those studies are important to demonstrate the vaccines are safe and they're making an immune response. The key next question for the trials was whether they made good immune responses in older adults, so those over 50, over 70, and even very old adults. And that was the phase 2 trials. Phase 1 started on the 23rd of April, and phase 2 started just 1 month later. And so we were able to move so swiftly through those early studies to get to the pivotal part, which is to test whether the vaccine actually works. And for that, you need tens of thousands of people in order to take part. Now, I think one of the things that is so striking about running clinical trials in 2020 was when we said we needed people to volunteer, tens of thousands of people came forward. In fact, hundreds of thousands came forward saying, no, we'll take part. It's our duty, we've got to do it. And there was no hesitation for those who came. And then when they came to the clinic, we said to them, I'm sorry, we don't know if this vaccine will work. We actually don't even know if it's safe. But we want you to take part in the trials. And despite that, 25,000 people took part in our trials here and in Brazil and in South Africa. Fortunately, the vaccine does work, and it did provide excellent protection. The key thing is it stopped people from dying or going into hospital. And that's really what ending the pandemic is about. It's that is the key public health goal that there has been. And indeed, that is the case for all of the vaccines which have been developed. They've shown in the clinical trials that they are almost 100% effective against the most severe disease. Now, of course, nothing is ever 100%, so you can't get there because some people don't respond to vaccines because their immune system doesn't work. There are reasons why nothing is 100%. So we, in setting up the trials across all those countries, there was a really important goal, and that was to make sure that we were able to capture a wave of disease and also to have data in different communities from all around the world, because we were absolutely determined in our vaccine development program to have a vaccine that could be used everywhere. So we undertook trials in Brazil, in South Africa, here in Europe as well, and working with partners also in South Asia. So that meant that we had the geographic and ethnic and social diversity needed to give people confidence that the vaccine could work in all communities. But also the scale is needed for the trials, because you don't quite know where the next cases are going to occur, and you have to have, sadly, cases happen in the clinical trials to know if the vaccine works. The initial thoughts were that we would get the results very quickly, because the modelers were predicting 500,000 people dying here in the UK just in that first wave. But lockdowns are incredibly effective in stopping transmission. And so when we started our phase 3 trials, the ones to look at efficacy, transmission stopped as well. And so although we could vaccinate lots of people, we didn't actually know how long it would take to get an answer. I should explain that when you do these trials, half the people get the new vaccine, the coronavirus vaccine, and the other half get a vaccine that won't protect them, so it's a placebo. And what you're trying to establish is whether those who have been vaccinated with the coronavirus vaccine are protected, and those who don't get it still get disease. And so whilst you're running the trials, you can't look at the data. Everyone is blind. We didn't know what the results were. The participants in the trial didn't know. And so you go through this process waiting for cases to accumulate. And once you have enough cases, you can break the code and have a look. And here in the UK, we had very few cases, as I'm sure you know, from the end of April. The number of cases was nosediving, and it didn't really take off again until the autumn. In Brazil, they had a moderate number of cases when we started, but then that number increased substantially. Whereas in South Africa, they had very sharp waves of disease that occurred over the course of last year, actually more or less coinciding with our cases here. And so as these waves of coronavirus hit, we started accumulating cases so that by the end of November, we had enough data to go to our safety monitoring committee and break the code and see the results. And so for me, at that point was a key moment, not least because I then had to go to number 10 and do a briefing at number 10 whilst Boris Johnson was self-isolating because he'd been in contact with the case, so he was on the screen. And myself and Chris Whitty were there at the podium announcing the results. I mentioned the partnership with AstraZeneca, and this is one of the most astonishing things, I think, about the development of the Oxford vaccine. We were determined the vaccine would be developed not for profit, because the last thing you want in a pandemic is to have commercial drivers for distribution of the vaccine around the world. And so in order to avoid commercial drivers, you don't want to have incentive to sell just to rich countries. And AstraZeneca came in and they said, yeah, we agree with that. This is one of the world's largest pharmaceutical companies. And so that was an incredibly important moment. And as a result, the vaccine is in over 170 countries today. There's 1.9 billion doses have been distributed around the world. And it's around 40% of the doses have gone through COVAX, the facility that delivers vaccine to low and middle income countries. And so I think we feel especially proud of that relationship with AstraZeneca because it's allowed a publicly funded university to actually meet our mission, which was to avoid profiteering in the pandemic. So from that first needle going in, which was the 23rd of April last year in the phase 1 trials, to the MHRA, our regulator in the UK, authorising the vaccine, was just 8 months. And when we started, we were being told this will take years before you'll have a vaccine. So here in November 2021, it's not been years. There's actually now 50% of the world has been vaccinated with one vaccine and more another with at least one dose. Sadly, still only 3.7% of people in low-income countries have been vaccinated. And that is, I think, a pretty shameful thing to have to say. And of course, most of those countries are in Africa, but there are other low-income countries in South Asia, as well as in parts of Latin America, where they're very much under-vaccinated. And the impact of that is that from where we sit today in our relative comfort, debating children and boosters and so on, in that context, we look back over this year, and by May, we had, across all of the developers, made enough doses to prevent almost all of the deaths that have occurred in the world. But since May, another 1 million people have died, simply because, despite everyone's efforts, a lot of those doses have been diverted to low-risk individuals and to those in high-income countries. So what we don't have is a good system for making sure that we really do have that global health goal that we set out with from Oxford across the whole of the system, to allow all of the doses being made in the world to be given equitably to those who are at highest risk of dying. So there are now over 7 billion doses have been given in the world. And in the last month, there's been more third doses given in rich countries than there have even first doses in the poorest countries. So we're still in this situation with inequity, despite the efforts of one developer. And as I say, I'm quite proud of our efforts, but it's not enough. You have to have a global community that is focused in the same way. And that hasn't happened because, of course, most of the decisions about how vaccines are used are national decisions. And it's absolutely right that our politicians, who we elect, their first duty is to us and to make the risk for us as low as possible. But unfortunately, that is often at the expense of a global public health view. I'm not sure I know what the solution to that is, but it's something we have to manage as an international community for the future, because I think of one thing we can be certain: there are going to be more pandemics to come. For me, there was an absolutely overwhelming sense of relief in January, when the first doses of our vaccine were given, the 4th of January, to a few individuals in Oxford, and I was there. I was vaccinated on that first day as well, which was a special moment for me to receive our own vaccine. But actually the most exciting moment was in February, when the World Health Organization licensed both a Korean manufacturing site and the Serum Institute of India, who make our vaccine, and those first doses were distributed through COVAX. So really from February is when the global distribution started, and that for me was a really moving moment. And in total now, COVAX has distributed 440 million doses around the world, which is just a really amazing figure. And that is going to dramatically increase in the months ahead, which gives me, I think, more hope about the distribution. There are more doses now available. Manufacturing capacity is massively increasing, which means that there will be more doses for those who are at the greatest risk. But as I said, unfortunately, for many of those people who have died in the last 3 or 4 months, it's just too late. We have, I think, perhaps now, one really critical question, which is what's going to happen next. And I think it's worth just spending a few minutes on what the world looks like today. I've mentioned the inequity, but that we are actually in an improving situation. We have a very high proportion, if we focus domestically, of people in this country who have been vaccinated with 2 doses. And those 2 doses, for the vast majority of people, means that they will never now get severe COVID in the way that we saw it in the intensive care units last year. I believe that disease is, in people who are vaccinated, is a thing of the past. Now, people are still being admitted having got COVID at this moment, and you see that in the figures every day. So COVID is still putting people in hospital. But most people who are going in now are there for a very short period of time. They're not there for many weeks and then ending up in intensive care. what's happening is that most of those are people with other health conditions who their health condition is destabilised and they've become unwell and gone into hospital. The length of stay in hospital of people who test positive has dramatically fallen. And so that means actually we're dealing with a slightly different disease now in the double vaccinated population. What the third doses will do is it will stop infections, and so many of those people will no longer go into hospital, even though the illnesses are generally much less severe than before. The people who are in intensive care today are the unvaccinated. That is the group that we're most worried about still, are those who have not had any doses of vaccine. There's about 5 million of them here in the UK. So it's a substantial number of people who are still at very high risk. And what the virus is doing is it's evolving alongside our immune systems. And what that means is that in a highly vaccinated population, it has worked out, not intentionally, it does it by accident, but it has found ways of continuing to transmit. And you'll see whichever vaccine people have had, you can still get infected with coronavirus. And now if you're healthy and you just get a mild cold, that doesn't really matter. And in fact, that cold will give a further boost. But that is actually what the future looks like. The future is living with this virus, causing mild infections in a large proportion of the population. But like flu, there will be some people who are more susceptible to being destabilised and will end up in hospital. And so the future, what's called endemic COVID, is something we haven't quite worked out what to do with yet. Are we going to need annual booster doses for some people in the population to continue to protect them against hospitalisation? Or are we going to reach a point where we're immune enough that further doses don't really make very much difference? We don't know at this moment. There's a lot of uncertainty about what happens next. Immunity is reducing in the population, which is another reason why there's more spread. It's even amongst vaccinated people, you can become infected more easily now than when you've just had your 2 doses. But that infection is the virus being in your upper airway, in your nose and throat. It's not about the virus being in your lungs. That's still today, in people who are vaccinated, a very unusual event. And that's, I think, incredibly good news. We've got this improving situation now in the UK. We've got people, high proportion, double vaccinated. The boosters are improving that immunity even further. Plus, there's been, over the last 3 months, a lot of transmission, which will improve the immunity even further in those who have been infected and have not developed severe illness. So I think we can look forward to an improving situation in the months ahead, made even better by the continuing boosting program that's going on at the moment. The downside of the program, of course, is it takes doses out of the system that could be going to Africa for the people who've had none. But that's sort of a separate issue which governments need to wrestle with from the issue about what we should do ourselves. If you look at the levels of protection against severe disease and death, the vaccines are still giving somewhere around 90% protection against severe disease and death. And so you'll see data reported showing in Israel that the boosters have an even greater impact. But if you're already at somewhere around 90%, a greater impact is only bringing you up a little bit, 90 to 95 or 98%. So that's a small improvement. It's an improvement in protection, but it's relatively small. Whereas if you're unvaccinated, you go from 0 up to 90%. And that's why having a dose that's spare, giving it to someone who's unvaccinated, has a much bigger impact in the world than the boosters do. But that doesn't mean to say that the boosters won't make a big difference to some people whose lives will be saved by them. It's just it's not as common as it would be in an unvaccinated population. So in the what happens next scenario that I'm talking about, as I say, I do think there's an improving situation, but there is a worry that where we are at this moment with still so many unvaccinated people in the world, by the end of this year, the current prediction is another 300,000 people will die globally. And many of those are actually going to be in Europe, and particularly in Eastern Europe, where vaccine coverage is low, but also in other countries where there is very low uptake. And if you want to guess what vaccine coverage is like, you just need to look at the country's GDP. And if it's low GDP, there's almost no vaccines. If it's high GDP, there's 2 or 3 doses for almost everyone. And that scenario is one which is true across almost all health measures and always has been. And so I think, if we want to have an impact on health internationally, it is about focusing on those populations who remain at the greatest risk, the most deprived. And one of the reasons why that's important is not just self-interest, not just the moral situation, it's also self-interest. Because if we look, for example, today in parts of Africa, the knock in the health system caused by COVID means that many children weren't vaccinated. And there are measles epidemics occurring, which will then spill over and spread to children here in the UK and in other parts of Europe, as has happened over the last decade. And children died here because of transmission of measles in our population. So there are really good reasons in order to improve our own protection by making sure that people everywhere are vaccinated. There's also a good economic reason. That part of the problem we have economically is the global economy is in a bit of a state. Once the pandemic is no longer upon us, then the economy recovers globally, and that's good for us. It's good for trade, it's good for travel, it's good for tourism. So all of those things need to be in place. So there's self-interest reasons why we need to distribute vaccines more generously than we have been doing so far. So I wanted to just close by reflecting back on George Shaw, and in fact, the words that we had were the words I was going to use. George Shaw was someone who, in this city, was recognised as someone who was really pioneering in his focus on those individuals who were in greatest need. If people couldn't pay, then he didn't demand it. And that, I think, was something which is why he's so warmly remembered in what was written about him, because his focus was on making sure that everyone was protected in society. And I think would be a nice legacy to have from this pandemic, is that we have a different view of the way that we look out to people in other countries who are all part of the same family and make sure that they're just as protected as we can be here in the UK. Thank you very much.
Thank you very much indeed. And I don't know about colleagues in the audience, but just going back through that chronology, sitting there sort of reliving, thinking, oh yeah, I remember watching that program and so on. It's quite a thing to need to keep telling the story, isn't it, with all of this. There's an opportunity now to ask questions of Andrew. I'll bring the microphone round. And just whilst you're thinking about a question, perhaps I'll just kick off really. You'll be aware that COVID affected Leicester greatly, and partly as a result of being a community where there is significant poverty and a community where there is significant ethnic and cultural diversity. You spoke about vaccine inequity in global terms. I just wonder whether you might reflect a little on vaccine inequity and health inequity in relation to this COVID pandemic, in relation to those inequities in our own society.
Well, you're absolutely right that when you look within the UK, there is huge health disparity, and that is despite having the National Health Service, which is a great leveller in a sense, in that it is available and free for all. But some of the figures around access to healthcare, even in this country with the NHS, show that if you're in a wealthy area, you're more likely to get seen quicker, and the waiting lists are shorter. So all of the things which actually you might want to improve in areas where there's greater poverty actually don't work. Well, you probably need more money there in order to have a bigger impact on people's lives. But you're absolutely right. In every measure, if you look at vaccine coverage, it's lower in the most deprived areas for children, just historically, as well as the burden of vaccine-preventable infectious diseases. And then here in the pandemic, the worst outcomes have been in those most deprived communities. In terms of vaccine access, I think there is one of the big issues has been within some communities, very negative messaging that has been there, and it's something which I think actually now the UK has done quite a good job in managing. When I say the UK, it's actually community leaders, religious leaders, with some exceptions, have done an extremely good job in making sure that their communities get the right messaging. But there's no doubt that at the start of this year, it was a huge problem and continues to need to be tackled. We need to understand why some communities do have such a fear of vaccines.
So,
thank you so much. I've been hearing, people still being a bit kind of low key about where we are, and I sort of think to myself, my goodness, if we didn't have a vaccine that works, think how awful that would be. Just think back to how we felt in April, May, even last year. But all the time, the story coming through of what the work was being done in Oxford and elsewhere, and we're really grateful to that. Something that really interests me is 30% MERS death rate, 11% SARS, 1% COVID, 50% Black Death. Why doesn't everybody succumb, particularly to the Black Death?
That's a good question. I don't know the answer for the Black Death. The difference with MERS coronavirus is almost certainly to do with the virus. Its spike protein binds onto different surface receptors on our cells, so it finds different cell types in our bodies and is more likely to cause more severe disease. So I think that's one of the key issues with some viruses is where they bind. And in fact, even with influenza, there's some fascinating studies with some of the flu viruses that infect birds, and depending on where exactly they which cells they prefer to stick on, they might be mostly in the gut, or they might be in the upper airway, in which case they spread well. But when people die, it's because they bind very well in the lower airway. And so the dangerous viruses are the ones that cause lots of problems in your lungs, but also are good at sticking in the upper airway and can spread. And the thing about many of the flu viruses that haven't spread well, like bird flu in 2000 and whatever it was, 5 or 6, and the H5N1 virus, that bird flu virus was very bad because it got into your lungs, but it again didn't spread very well because it wasn't very good at sticking in the upper airway to spread between people. So one of the things is just the characteristics of the viruses, which make a difference to what the outcome would be. But the other side is what we're like, and we have now got lots of information in COVID about what the risk factors are. So people who are overweight have a greater risk factor. People who are older are more likely to get severe disease, and certain underlying health conditions as well. And it's probably those other features that make individuals more susceptible, but also we've got a virus here that tends to be much less likely to cause the severe lower respiratory component.
Can I ask about your view of the relative benefits of vaccinating children? I guess particularly in the light of what you were saying about the morality and equity of using vaccines globally.
Well, children have a much lower risk of severe disease. I mean, incredibly low risk of severe disease compared with older adults, and it does gradually increase as age increases. So that doesn't mean to say that there aren't some children who will get very severe disease and die, and it's just very rare. But it means that if you vaccinate children, that a high proportion of them will have little benefit because they were going to get mild infection, even no symptoms at all. And so when you're trying to balance up the marginal gains for the whole population of vaccination versus the small risks of the vaccines, it becomes quite closely balanced. And in fact, with teenagers, it's certainly just in favour of vaccination, which is, I think, why in the end we have a vaccine programme for teenagers. It's interesting that JCVI's view was that it's just in favour of vaccination, but they didn't recommend it. But when you add in the impact on education and mental health, the chief medical officers thought that it was a good idea to go ahead with vaccine. And so that, I think it's rational to have a view to vaccinate or not vaccinate. You can make arguments in either direction. And that's not that it's people are getting it wrong if they believe one or the other. It's just that it's a bit more marginal than in other age groups. If you're talking about someone who's 80, there is no question vaccine needs to be given. But it's a bit more marginal with those younger age groups. And I think we've got a sensible policy here, which is to vaccinate, if that can help keep children in school, because the biggest threat of the pandemic for most children has been the impact on their education and their mental health.
Andrew, it's lovely that Leicester are putting on a fireworks display for you, but it's Diwali today, so happy Diwali, everybody.
Yes, thank you again for your history of what's been happening. My question is really about those people who are against the vaccine and being vaccinated. I've collected a little bit of anecdotal evidence as I've listened to people on my allotments at African Caribbean funerals. And it seems to be that they're concerned about what the government is asking them to put in their bodies, and they don't know what it is. And I'm not sure that I actually knew what it was after listening to your talk, because I thought it was this inactivated dead stuff, which I did actually explain to an African Caribbean man. He was quite pleased that I said that. But of course now I realise I was wrong. It's something to do with a spiked protein, which I have no idea what it is. And if I don't know what it is, and I'm fairly educated, I'm sure not many other people do. So I suppose my question is how do we communicate this stuff to people so that actually makes some sense about what they're placing in their bodies to vaccinate themselves, to keep themselves safe?
Yeah, I think you're right. I mean, there are an enormous number of different vaccine types for coronavirus. And so but they all are targeting one protein from the virus called spike protein. So in a sense, all of the vaccines are doing the same thing, which is trying to get our immune system to recognize a bit of the virus. But there are, amongst the different technologies, very different types of vaccines. And so to go into the technicalities of each of those is complicated. It's very easy to do it at a sort of a very superficial level. But I think you're right, that communication of the detail is complicated. And actually for some people it makes it even more worrying when you communicate the detail, which is not the direction of travel. Yeah, I mean, I think certainly when I look at the media, there is pretty good explanation out there in the media of the different types of vaccines. But I think people would really have to search for that, and they'd have to be looking at the right sources. The Daily Mail actually has done some really good stuff on it. Financial Times does. So I think across the BBC does. So across the media, you can find the information. But I think one of the problems for many communities is that they're not accessing those types of media. And so the information they're getting is from other sources which may not be so reliable.
First of all, bravissimo, bravissimo. I don't think we can overstate the terrific work that your team in Oxford have done. It's just truly amazing. And yeah, just staggering. And I was just wondering, we obviously other pandemics are going to come, and who knows when. Are we, with all this wonderful collaboration that you've established with China, with Brazil, are we now set up as a planet to deal with the next pandemic in a more equitable and just way than the sort of situation that we now face?
Well, I think the first bit of the question is, are we better set up, even just to recognise when the next pandemic is starting? And I think we are probably a bit better than we were, but not much better. The only good global surveillance we have had is for influenza. And that really now, I think people are recognising needs to be enhanced. We're adding in coronavirus and some other viruses, but it needs to be, I think, much on a bigger scale so that we do pick up the next pandemic as early as possible, because you really do need time to be able to respond. As far as collaboration scientifically is concerned, I don't think we've ever been in such a good place with that. I think if you look at the connectivity through Zoom calls, through emails with scientists all over the world, then it's astonishingly good now, and better than it was even 2 years ago. But as far as the justice is concerned, I think you can take two views. One is that the problem is now recognised and solutions will be put in place for that. The other is that nations will actually recognise the risk of nationalism around vaccines and entrench even further. I'm not quite sure what happens next. I am encouraged for Africa that there is a huge amount of work going on to invest in manufacturing in Africa so that at least if there are vaccines, they can be made in Africa in the future, which defends that continent against nationalism elsewhere. But even that's a bit simplistic because the supply chains of these raw materials have to come from all over the world. What we source here in the UK for manufacturing, the raw materials come from the US and from other countries, and you can just as easily have a blockade on those materials that would reduce the ability to manufacture. So I don't know. I think we recognise the problem.
Perhaps one last question. Anybody champion at the bit?
Do I need it, David? You mentioned inequity of distribution, and I'm curious about who is empowered to make the decisions on this. In the case of your vaccine, it's clearly not Oxford, but how free a hand does AstraZeneca and other companies have in making the decisions about where the vaccines ultimately end up?
Well, the way where vaccines go is really there's, I guess, three different mechanisms. The first is the contracts that have been made with nations and with regions. So you'll be aware that this year there was lots of controversy between AstraZeneca and the European Union about whether they were fulfilling their contracts during the first part of 2021. And just as there were contracts with the UK government and with other governments around the world. So those are supply agreements which mean that once doses are manufactured, those agreements need to be honoured, all not-for-profit, I hasten to add. Then the second has been the agreements with COVAX. And for us, this was the most important part of the setup, that AstraZeneca and Serum Institute of India, who make our vaccine, have both made major agreements with COVAX to supply them. And that went extremely well initially, but then there was a huge outbreak of coronavirus in India. And the Indian government stopped the Indian manufacturer from being able to export any doses. And so that had a huge impact because those were the doses for Africa. Now, of course, it's completely justified for India because there were huge numbers of people dying from COVID and they really needed to vaccinate their population. But I think it shows the challenge of having major manufacturing in a country that has a huge population. If that had been a small nation, then that wouldn't have mattered. But the capacity needed, and we are talking about hundreds of millions of doses per month being manufactured at the moment in India. But it's still a drop in the ocean when you've got to give 2 doses to that country of more than 1 billion people. So I think that's been one of the major difficulties, was that COVAX was relying a lot on our vaccine, and India, the Indian government then put that blockade in place. So I think that's one of the key areas that held things up. And then lastly, countries have been donating vaccine. The UK has started donating some doses either directly to COVAX or bilaterally because they've now got enough supply. And as you know, the UK government had contracts for many more doses than it would ever need. And so those are being diverted, as is the European Union diverting doses to other countries. So those are the three mechanisms. The decision-making for that, obviously some of it is bilateral agreements with governments about donations. COVAX has got a system of equitable distribution. And in many ways, if we've got the supply into COVAX at the start of this year that was always intended from all of the developers, then the world would be in a very different place. But when supply is constrained, then people are worried about focusing on their own populations.
I'd like to invite Gordon Arthur, who's chairman of the Cathedral Council, just to come and say a word of thanks.
Sir Andrew, one particular phrase which became current during the pandemic was follow the science, a phrase dreamed up by political spin doctors which did not have a very clear meaning. However, one thing we have all learnt through these terrible months is how many very eminent scientists whose research and hard work has helped to contain the virus, and how many we have in this country, and how fortunate we are. Tonight, I mean, you are clearly one of them, and tonight you have started right at, not quite the beginning, but in 1346 with the Black Death, moving through cholera, SARS, MERS, and ending up with the spike protein, which was certainly a new expression to me. I think two good things you have focused on is the collaboration, the wonderful collaboration between nations and between scientists of all nations, and what the wonderful results that has produced. And let us hope that we will have similar collaboration on other fronts as well, not least climate change. We've also commented on the volunteers who put themselves forward for trials. Another wonderful example of humanity. And then you focused on the problem of the 5 million unvaccinated people in this country and how we can best persuade them to perhaps be vaccinated. And also the way we have to find to give more people vaccination throughout the world. You've demonstrated your considerable expertise tonight. You've spoken to us also in very simple terms which most of us can understand. Thank you very much indeed. And let's hope that the skill that you and your colleagues have demonstrated will encourage governments to support more research in the future. Thank you very much indeed. Thank you.
There is a drink in the South Aisle, and Andrew certainly will be around for a little bit afterwards, so if you've got questions and want to meet him and so on, we'll be around. Thank you for being here. And sorry it's a bit chilly, but in order to make the place accessible, the door has to be open. All that will change in 18 months' time, but the builders have finished the work. So thank you very much indeed. Thank you. Andrew, thank you. Yeah, absolutely. Yeah, no,